I will be focusing more on that because most of the theory is there in the Google. So what in our day-to-day time we are doing and what practicality or what problems we are facing. Even though we are working with a male infertility or unexplained infertility or polycystic ovary, the induction is a mandatory thing which we should be done. We are the days when we are thinking that more the number of the follicles, we are more happy. Now here we are bothered about more the good quality of the oocytes or the eggs. So how it works, and then which one will be better for this patient or which one will be better for that patient and which to use, because one size not fits all. So it's very important.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
So good evening everyone, a warm welcome to you all. I'm really thankful to the platform who gave me the opportunity to connect with you all. So I have been asked to speak on ovulation induction uh, for the it should be in a level 1 clinic, like for the beginners. This was the idea which have been sent to me for the upcoming infertility specialist, you can say, and the time allotted to me is 1 hour. So I will try to compile my talk in 40 minutes, or you can say 35 minutes, and I will be really happy if you comment and put your questions over there, because so that we can have an interaction at the end for more and more time. Because if only why I go on speaking and there is no interaction, there is no worthwhile going, because the class which have been asked to me do is the practical guide to ovulation induction. So what we are doing and facing the problems in our day-to-day clinics, day-to-day OPD, I will be focusing more on that because most of the theory is there in the Google. So what in our day-to-day time we are doing and what practicality or what problems we are facing. I will be very happy if you start commenting over the this chat box and all. So normally the level 1 gynecologists who have just passed the PG or have started their career, or the few elderly one who have completed the career but now they are fixed to go for the infertility. So how to start the practice and how to stimulate the patient, that's very important thing. Not going in detail of what is infertility, when we start the treatment, we all are aware that if a elderly couple is not going to conceive, and after 6 months or so, we are going to, we should ask them to come to the doctor, and if a younger one for more than 12 years, if they are in the regular sex, unprotected sex. I think which is a dream nowadays. Every couple is like very difficult to have. But even though if they are more than 35 years, and 6 months they are together, they should consult a fertility specialist if they are not having a baby. This is not an issue. We all know that infertility is going in increase day by day. The data is gradually increasing. I think this is 1 or 2 years back data. 8 to 12% of couple. Nowadays it has come to 14 years. 14% of the couple is infertile, and the primary infertility is again in rise. We are not going in detail of the what is the region of this. Again, a WHO survey that 1 in every 4 couple in developing country have been found to be affected by infertility. So again, the point is that why we are focusing in ovulation induction, or you can say control ovarian stimulation. Why? Because it's like exactly induction of ovulation. What I feel is the backbone of the infertility treatment. Suppose you didn't have a because even though we are working with a male infertility or unexplained infertility or polycystic ovary, the induction is a mandatory thing which we should be done. So that's why, and this is basically like what I normally tell, this is basically like a mathematics. So how much to give, what to give, and what the outcome is there. So more you practice, more you learn, the more is the outcome. And again, we are very much aware is that ovary is a dynamic organ. Its metabolism keeps on changing. So in some month, you will find that there is a very good follicle is there, and in the other one, there is not. So it's a dynamic organ. The metabolism varies on lots of things because of the hypothalamus and all control axis. So definitely it's a challenge, and gone we are the days when we are thinking that more the number of the follicles, we are more happy. Now here we are bothered about more the good quality of the oocytes or the eggs. Normally, I always tell when we are starting for the induction, we should know the basic physiology, because the patients which are coming to us for the baby, we are more worried. We normally what we do, we try to compile to the natural physiology of the body. So we all are aware that all in the females the follicles start forming inside the utero, and when the baby is born, when the female baby is born, they are arrested at metaphase one state. At the time of ovulation is only the conversion of one to two, then it leads to the meiosis is completed. So that's why it say that in a female girl, if it is inside the utero, the all the oocytes are there already formed, and there are millions of there. So it's very important to understand the primary oogenesis and how the ovulation happens. Then only we can control the cycles. This HPO axis. Actually, it's very important to understand how the female physiology, the reproductive system works. Like hypothalamus, then is the pituitary, then is the ovary, and then is the uterus. We all know that the GnRH and FSH, LH, ovary, and then uterus. And if we understand this HPO axis, then we can understand how the molecule works and which molecule we are going to use and what to use at what time. That's very important. So because everything is controlled in this HPO axis, and there is a reverse correlation with all the things except the prolactin. So there are different types of infertility, and now I'm coming to the basic thing, how we are going to stimulate over what are the different molecules we are using for this stimulation. So initially, when we are talking about the beginners, like those who are working for the at the level 1 clinic, those who are stimulating for the time intercourse or IUI. In the level 1 clinic, we have the permission only to do the IUI or time intercourse. So ovulation induction, we can use gonadotropins also. So in this lecture, I will be talking about the using the molecules like oral stimulant drugs plus gonadotropins. And is a bit of, if time permits, we can talk about the antagonist. So again, I am emphasizing on things that is very important to understand this hypothalamus pituitary ovarian axis. GnRH is released from the hypothalamus, and then under the influence of GnRH, there is FSH and LH release, and under the influence of FSH and LH, there is estrogen and progesterone, and then the cycle works. So one by one, we will understand the molecule first. So how it works, and then which one will be better for this patient, or which one will be better for that patient, and which to use, because sorry, because one size not fits all. So it's very important. So the time tested in the very earlier molecule which we are doing in our school days is like, sorry, college days was clomiphene citrate, then the letrozole gonadotropins, the combination. I'm sorry. So clomiphene citrate is very commonly used in the peripheries with the general practitioners, with the gynecologists, because it's very simple to use. I'm sorry. It's cost effective, easily available. Nowadays, the other oral stimulant drugs are also available, and complication is very less. So it's a very time distant molecule. I think it has been, we are using for more than 100 years or so. But why we are not using very much nowadays? Because believe me, I think rarely any IVF specialists have been used, or in level 2 clinic, clomiphene citrate has been used, because mostly it has been used in the periphery, and when the patients come to us, I think 4, 5, 6 times they are already having the clomiphene citrate. I'm sorry for my bad throat. So why clomiphene citrate is a good drug and why clomiphene citrate is not very commonly used? Clomiphene citrate is a very good drug because the ovulation rate is very high, but the pregnancy rate is low. So why, how come, and what is the clomiphene citrate is a non-steroidal anti-estrogen. It is structurally similar to estrogen, but is an anti-estrogen and having a weak estrogenic property. And it binds to the nuclear estrogen receptors. So what happens? It depletes the estrogen, and when in the periphery the estrogen is low, the signals goes up, and there is a release of FSH and LH. So normally this is the mode of action of any these molecules. So clomiphene citrate, one of the important thing we have to understand is that it is a central action. It is an anti-estrogen and it blocks the receptor. So the estrogen is low. And so there is a signal going on that there is a false interpretation that the estrogen is low. So the hypothalamus triggers the GnRH, then the FSH, and finally the estrogen, and the follicles are formed. So one of the important thing is that clomiphene citrate is centrally acting. So it works over this hypothalamus. It blocks the receptors. So the estrogen is less all over like. So when the estrogen is less all over like, it is also less where it is needed like the endometrium. I will just compare the mode of action of these two molecules, then we can better understand. So now most of the people are now using letrozole. So why we have shifted from this clomiphene citrate to letrozole, or why we are more commonly using letrozole? So because unlike clomiphene, this letrozole has a peripheral action. It didn't act over the center. First of all, I will show you this slide. It is a aromatase inhibitor. So what happens? This aromatase is responsible for the conversion of this androstenedione to estrone and testosterone to estradiol. So if the aromatase, this is blocked, in the periphery, the estradiol is come and the estrone is low. Both are less. So the signal goes up in the back. Again, in the mind, it is very important to understand hypothalamic pituitary ovarian axis. So what happens when we are giving letrose? Letrose blocks the receptor in the periphery, so it is peripherally acting. So when it blocks the receptor in the periphery, there is no conversion of this androstenedione to estrone and testosterone to estradiol. So what happens? In the periphery, the estrogen is low. So when the estrogen is low, again the signal goes up and there is a trigger and there is release of blah, 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 blah. And finally, there is a follicles grows up. GnRH and then FSH and LH and then the follicles start forming. So what is the difference between the clomiphene citrate and what is the difference and letrose? Clomiphene is going to block the receptor in the center and letrose is going to block the receptor in the periphery. So what happens that letrose is not hampering the endometrium to grow. That's why the endometrium is very good. Endometrium is not hostile as we happen in clomiphene citrate. That's why when the people who are giving clomiphene citrate, they are adding some lubricants or some molecules so that the cervical mucus becomes very good. Or when we are giving clomiphene citrate, we are giving trigger late so that the cervical mucus is not hostile. So that's why now coming to the backslide, here you can understand like unlike clomiphene citrate, letrose does not have any effect on endometrium or cervical mucus. That's why even though the letrose has a monofollicular development, the pregnancy is good. And there is a thicker endometrium because the peripheral estrogen is not going to be affected. With thicker endometrium and increased stromal amount. And compared to clomiphene, that's why the letrose has high pregnancy rate. I will just repeat the same. When you are giving clomiphene citrate, it is centrally acting, and so block the receptors. The estrogen is low, but when we are giving letrose, it's a peripherally acting. So it's not affects the other parts like so the endometrium is good. That's why we consider letrose as a much better oral stimulant agent in compared to the clomiphene citrate. I'm not going in detail of the dose what we are using, either clomiphene, because clomiphene you can start from 50 milligram, or you can enhance the dose to 100 milligram in next cycle. Again, you can increase like, but not more than 150 milligram. And these are for the younger patients. Again, letrozole when we are starting. So I hope you can understand why we are more preferably using letrozole and why we are not more commonly using clomiphene citrate. If you have any query, you can post your question. I will re-clear it after 30-40 minutes. So, and again, extended letrozole has a different doses, like you can start from day 2 or day 3. There are different protocols, and again, letrozole, I feel, is a wonder molecule. We are very frequently using even in the IVF cycle for the good endometrium, for preventing the premature adolescence and blah blah, not going in detail. So if we are using for ovulation induction, for IUI or for time intercourse, we can start from 2.5 milligram. We can start from 5 milligram a day, or 5 milligram daily from 1 to 2 day. Again, some people prefer to give 10 milligram stat or 20 milligram single dose. A protocol 7 days, you can give 7.5 milligram daily. So there are different doses of protocol. Again, one important thing I just want to share with you, that before you are reading any patient, you are talking to any patient, you are looking over the history of any patient, it's very important that in your mind there should be a target, like what you need in this patients. So the what should be the ideal target you need? Yes, we all are aware that what ideal target we need is that from day 11 to day 13, there should be at least 3 mature follicle with good endometrium, so that we can give a trigger. This is a target. Now the patient is in the front of you. You can see the BMI, you can see the past history, you can see the age, we can see the antral follicular count, the baseline scan. I'm not going in detail of this because it will be a huge one. I have to ask to talk only on the induction. So it's very important what dose you need to start. Either the patient has come to you for the first time and it sees a raw patient, so you can start from see the lean and thin patient. Either you are stimulating for the male infertility, or you are stimulating a patient for PCOS who is obese and who had already undergone 2 or 3 stimulation from the other doctors. So it's very important to go through all the papers if a patient is coming to you, and what was the past stimulation done. That is also very important. If how much dose was given, then accordingly you can start your stimulation. So you the one that's the important, when the patient is in the front of you and the whole history is there, then you can make. Secondly, important thing is that when you are working with the patients, then HPO axis will always should always be in their mind. So, so that then only you can make a proper food. Then only you can make a proper follicle. So, what was the hormonal level on day 2? What were the baseline scan? So, how we can modulate these molecules? These are all the molecules, and the target is 2 to 3 follicles on day 11, day 12, or day 13 with a very nice endometrium triple lining, so that we can give the trigger and plan our IUI or time intercourse. So, how to carry your patient from day 2 to day 11 or day 12? What molecules should be used? That's the very important thing. And this protocol should always be set in your mind when you are interacting with your patient for the first time, looking over the BMI, looking over the age, looking over the previous stimulation, looking over the antral follicular count. That's very important. Then only you can regulate your dose. Either you are starting with clomiphene citrate, you are taking letrozole. When you are adding the gonadotropins, which molecule you are adding? Either you are adding recombinant. So I'm going ahead. I finished this clomiphene citrate and letrozole. I'm going ahead with this. So now I am coming with the gonadotropins. What happens? Simple letrozole most of the time didn't work. Then again, the those who are the beginners, I'm not telling, they get scared of which molecule to be started and when to be started. Again, it is very important to understand we are following our natural body physiology. We have to follow that what already is there in a healthy fertile female. We just try to club up the things. That's very important. So if and gonadotropins means, again, is very important. Sometimes if you say gonadotropins, we will say "Oh, कौन सा लगाओ, recombinant लगाओ." It's very important that gonadotropins, again, close your eyes and think about the HPO axis. So hypothalamus, that is secreting GnRH. Then the pituitary, that is secreting FSH and LH. So this FSH and LH makes the gonadotropins. Now there are lots of molecules which are available in the market. They may be pure gonadotropins, they may be combination, they may be highly purified. So which one is needed? Now again recall your mind and just think of what is the normal physiology and which hormones is there on which day. Then add to your patients. So it's very important to do the baseline scan, baseline blood marker, then only. So again, the basic, this is a very important slide you should understand that in a normal body physiology for the first 5, 6 or 7 days, we need FSH. FSH is needed for the recruitment of follicle or selection of follicles. Look, as I told you in the first slides, we had millions of primordial follicle there when a baby girl is born. And in every ovulation, they are converted from M1 to M2. For the first half of the cycle, from day 2, day 3, day 4, day 5, it is the FSH which is the predominant hormone because they recruit which follicle which move ahead and select. Then after 6 or 7 days, LH started forming. So now LH and FSH both is responsible for the growth as well as the maturation. And when the follicles become dominant, like and is mature, there is looking over the estradiol, there is a LH surge and ovulation happens. So HPO axis should always be in our mind. Baseline scans should always be done. Baseline blood marker, I'm not going in detail of baseline scan or baseline blood marker. Either you start from letrozole or you start from clomiphene citrate. The choice is yours because you have seen your patient, you know your patient very well. Either you are stimulating for the first time or stimulating for the fourth time. But it is important if you are planning to add gonadotropins, these things should be in your mind that which molecule is to be added and what is the day. Because in a general physiology, normal physiology, FSH is needed for the 5, 6 days for the recruitment and selection, and the combination is needed for the growth. So if we are adding gonadotropins on day 7, day 8, then you need a combination one. And if you are adding more earlier, as in the polycystic patients, sometime is needed, then you need the recombinant one. Only FSH is needed. Few things would be in my mind because I have normally seen the younger generation. I'm not telling the younger generation, they're very smart nowadays and they knew much, much more. I've learned a lot from them. But normally, when you're sitting in a clinic and you are not very into a pure doing, like you are a gynecologist who is doing deliveries and who is doing colposcopy and who is doing infertility also, because in the earlier days it happens like that. We also have gone through those phases. In that phase, suppose out of 30 patients who are doing only 3 patients or 5 patients of this infertility, you get scared of kya lagaun, kaise lagaun, kitna lagaun. So these worry come in mind. So go to your basics, like what you have learned in your PG days or your, that yes, we need this in polycystic patient. We all know that LH is very high, and so if we need gonadotropins, we have to give FSH. But in cases of unexplained infertility, or if we need gonadotropins on 6, 7 day, we need a combination. What is the dose we should apply? So again, if you have started letrozole, as I told you, your target should be day 11 to day 13. 3 beautiful follicles, 18, 20, or 22, with a very good lining. And you are all aware that these follicles grow at a rate of 1.5 to 2 millimeter per day. So if you have taken a patient at day 6 or day 7, and you have seen that there is a follicles of 8 millimeter, 6 millimeter, or 9 millimeter, then definitely you will need gonadotropins. Actually, I didn't have a whiteboard over here. Otherwise, I explained you properly. Normally, if it is day 6 and you feel that your follicle is 12 millimeter, you are very happy. You have to just follow those follicles. Again, I routinely say that it's very important to scan yourself, because your sonologist see only the follicle which has gone ahead of 10 millimeter. They never see the backward cohort which is staying behind 6 millimeter, 8 millimeter, 9 millimeter. So if you give the gonadotropin, suppose 150, and then next when you do the scan or your ultrasonologist call you, "Eh, इसको क्या लगाया है, इतने सारे follicles बन गए," या he will ask your patient and patient will come in a panic situation, मैडम डॉक्टर साहब बोल रहे थे कि कुछ गड़बड़ है, बहुत सारे अंडे बन गए. So always do a scan on your own so that you can see the follicle which is going ahead, as well as you can see the whole cohort which is coming behind. Either they are 3 or 4 or they are 10 or 20, plenty. In that way you can decide the dose kitna lagana hai. Again, I always tell that LH is a hormone which is needed in the right time in the right place. If you find very high LH on day 2, then again it's always better to modify the cycle to add some molecules. Why the LH is very high, the percentage of polycystic ovary. Then in case you do the normal management like lifestyle changes and other like mannitol and blah blah, so that the LH should come down. And again, if there is absence of L is like on day 8 or day 10 or day 11, like in elderly patients, so the follicle will not grow. So LH is a molecule right time at right place. High LH will lead to atresia of follicle, while if there is a low LH, the follicle will not mature. So that's very important to monitor this important molecule. So you have started to stimulate your follicle, a lady who is like 24 years old or 26 years old, and but is a bit obese, and you started with gonadotropin, suppose. Sorry, let's just check me out. And you started with clomiphene citrate, suppose, and you've given clomiphene citrate for 5 days or for 5 days, and then you've done a scan on day 6 or day 7, and you feel the follicle is not good, then you can add gonadotropins. If you're adding gonadotropins for the first time, again it's very important to do a scan, and on day 6 you find that all the follicles are a 4 millimeter or 5 millimeter, then you can add it in a you can add 150 unit of gonadotropins you can add. But if you feel that the follicle is 12 millimeter or 13 millimeter, then 75 is way enough. So it's an individual judgment, looking over the patient, looking over, and the most the only important, very important thing is that in your practice is that there will be no harm to the patients. So even though if you are like using for the first time, you can say to your patients that I am using a less dose because it may happen like there is a flare up of follicles. So it may be your homework cycle. So we can judge how much doses should be given to you. So if you started this solution for the first time, if you given clomiphene citrate, you find very good follicles, you're very lucky, give the trigger and do the IUI. But always when do the IUI is very important, and do the stimulation for the IUI is very important. You do the perfection to the cycle. It should be perfect cycle. Because normally you see in the periphery, most of the prescription comes. They are giving letrozole, again letrozole, again letrozole, and making a single follicle, a single follicle, and single follicle. Try to upgrade your skills. Suppose, okay, fine, it may happen that we make a single follicle giving letrozole because we are scared of, or we were not able to make out what is the threshold of this patient. But the next time you just dare off and add some more gonadotropins so that we can make a very good 3 follicles on day 11, day 12, or day 13. That's very important. So add clomiphene with gonadotropins so that we can make 3 follicles. Again, I have told you the disadvantage of clomiphene is the androestrogenic effects. In this way, you can modify your cycle. You added clomiphene, then you can add HMG, and if you are scared of, call alternate day this patient for the scanning. If you don't know how to scan, send to the ultrasonologist, but if you have a machine, recheck you. In this way, you can improve your level and you can justify your patients. So finally, we have made a very good follicle. We have given the trigger and we've done the IUI or time intercourse with clomiphene citrate. Again, if we are adding Letrozole, we all know the benefit of Letrozole is much more because it works much more better on the endometrium. So you can add clomiphene citrate with you can add clomiphene Letrozole with gonadotropins in the same way. Again, no one can decide you ki how much gonadotropins you are as no one can decide you how much bread you will eat. It's you to decide आज मैं एक ही bread खाऊंगी या एक ही रोटी खाऊंगी. The same way you are the best judge to your patient who is sitting in the front of you कि कितना gonadotropins देना है और कितना आप handle कर सकते हैं. That's very important. So as either it is 75, it is or it is 150. Either you call for the sonography for alternate day, or you call every or on the third day. It's totally depending upon you. And one thing is also very important: your endometrium should go in a parallel way. You have made very good follicle on day 11. There are three follicles of suppose 14 millimeter, 16 millimeter, or 19 millimeter on day 11, but your endometrium is 5.6. So normally it happens when we are adding gonadotropins as a byproduct, the endometrium is very good. But if the endometrium is going slow, like in the elderly patients or in the polycystic patients, so you have to match your cycle in the proper way so that when the follicle release, you have a very good endometrium because the ultimate target is the pregnancy. So we have given clomiphene citrate single, we have given letrozole single, then we have added clomiphene citrate with gonadotropins, or we can add letrozole with gonadotropins. Not going in detail of study, we all are aware that letrozole with gonadotropins had a better outcome than clomiphene with gonadotropins. So these you have done. Now, again, there are two types of regime which I think you people should understand, those who have started their practice and started using gonadotropins. Because दर्द तो सबको लगता है, आज भी मेरे को लगता है. If the call, अरे मैडम पेट में दर्द हो रहा है, and we get scared of because we all are doctors and we feel यार pregnancy आए ना आए complications नहीं होने चाहिए. So for the beginners, this is very important, the step up protocol, because as I told you, I use one braid and you eat two and other is three, so the threshold is different for each and every person, every patient. So FSS threshold actually is very important to know. So that's why if you are confused or if you are not able to make out ki kya karu yaar kitna lagaun, so always make a plan for 6 months. आप इस बार नहीं बताइए कि आपकी प्रेगनेंसी आ ही जाएगी, तुम्हारे अंडे बन ही जाएंगे. So you interact with the patient for 30-40 minutes, explain her everything, and tell her because you are very like polycystic patients, I will try my best that if I can make you good follicles. But if the follicle we are not able to make, it will be homework cycle so that we can understand how your body is responding. Then you are in the upper hand. So that even the even the madam so to follicle ही नहीं बना pregnancy का होगा they left. So it's very important to explain your things because most of the time it happens like we are giving and there is no follicle. That's why it's important to understand this term, the FSS threshold. It's a critical point at which ovary respond with monofollicular development. It may be 225 IU for A, or it may be 150 IU for B, or 75 for C. So I always tell, go in detail with your colleague's prescription who have treated the patient earlier and find the flaws over there. कब ट्रिगर दिया था एंडोमेट्रियम, तो बहुत ही थिन था, इसी में ट्रिगर लगा दिया, या प्रोजेस्टेरोनाइज हो गया था, लेट ट्रिगर गया. So these things are very important. So suppose your colleague has given letrozole plus 150 of HMG and the follicle was not formed properly, or the follicle was formed on day 16 and there was only one follicle, then you have the clue in your mind. You are giving letrozole and then 150 on day 6 and 150 on day 8 in a single shot, and call your patient on day 10 आराम से. बार बार स्कैन क्यों करना है, इतना टाइम क्यों वेस्ट करना है? Because you have known the FSS threshold of that patient which was done by me, or pregnancy nahi aayi. So that's very important. And if she is coming for the first time, and you are a bit scared in your mind कि कहीं ज़्यादा अंडे ना बन जाए, then go on experimental way, कितना लगाऊं. And suppose you have done everything, and we know that in IUI it's not more than 20% anything. So even the follicle was formed, even you were given a timely trigger, but the pregnancy was not there. Then go for the step down protocol for the next time, because now he's become wiser and you know that this patient needs this amount. So what happens when we are doing the step down regime? Sorry. When you are giving the step down regime, you are giving a very high dose. If you start at 150, or suppose in the last cycle you felt that there was 225 international unit gonadotropins you were given, and there was only one follicle which was also late. So in this time, you can add earlier 150 and then 150. You will see that the amount of this gonadotropins was less because it was started earlier. आपने जल्दी ही 2 रोटी सुबह ही खा ली तो आपको दिन में 1 ही रोटी की जरूरत पड़ी. So but step down protocol is always given when we are aware about the FSH थ्रेशोल्ड. मतलब आपको पता है उस मरीज के रिक्वायरमेंट कितनी है और आपने एक बार उसको स्टिमुलेट किया हुआ है, बट प्रेगनेंसी नहीं आई. सो दिस टाइम यू आर ऑल्सो वाइजर, योर पेशेंट इज ऑल्सो इन योर कॉन्फिडेंस एंड सी नोज कि हाँ ठीक है ना डॉक्टर साहब तो ठीक ही बोल रही, अभी इतना ही तो लगा के अब मैं 8वें दिन ही आऊंगी फॉर दिस scanning. So for the IUI, clomiphene, letrozole combination, step up, step down. Now sometimes it comes in the point like polycystic patient. ये बड़े young भी होते हैं. इनके रिजर्व भी normally भी everyone prescribes like AMH करा ले. So इनके AMH भी बड़े अच्छे होते हैं. You can see sometimes 7 AMH because they are, but their antral follicles are there. So here, and you are very scared of because if they flare up, we are nowhere because आपके पास IVF का भी ऑप्शन नहीं है और वो पेन पकड़ के बैठी है. So here we go for low dose step regime. We give 37.5, 37.5, 37.5 for 3 days and then observe. Then again we increase the dose and then we observe. So these are the 3 things which you can use in level 1 clinic. Simple letrozole, simple clomiphene, step up protocol, step down. Here when we are using in PCOS patient, try to use the recombinant FSH because here you are starting this gonadotropins earlier. They had a high LH. So here comes the role of recombinant FSH in a gynecologist who are working in level 1 clinic. I think it's 939. So finally we have made very good follicles, and either using letrozole or using clomiphene or letrozole plus clomiphene, letrozole plus gonadotropins or clomiphene plus gonadotropins. Anyway, either using step up protocol or using step down protocol or using the slow release protocol. Then you have made very good 3 follicles and very confident. There's very good follicles on day 12 with a good triple lining with good flow. Now we are planning for your trigger. So trigger, normally we all know we are replacing the normal body LH surge. This we are replacing normally in level 1 clinic, we are replacing it with HCG, human coronary gonadotropin. Why we are replacing this natural LH surge with HCG? Because they have beta subunit common. So we are replacing the normal this natural LH surge with beta HCG. Again, they are, so this mid-cycle LH surge we are replacing with the HCG. Sorry. I think the time is less, so I will be slightly quick. So again, there is alpha surrogate same in that. So now again, there are lots of query like kitna use kare? 5,000, 5,000, 10,000, recombinant, lots of things there. Double trigger, dual trigger. So one of the very important thing is that natural LH surge, if you will calculate the LH at the time of LH surge, what is needed is only 15 international unit. That is the LH which is formed in the body for the trigger. Trigger means for the ovulation. Ovulation means conversion of M1 to M2. Again, actually I'm dealing with the ovulation induction. Everything is interconnected. Like at molecular level, the things are happening. At cellular level, the things are happening, and at cell level, conversion of M1 to M2. So I'm not going in detail what is happening there, but we have find a very good follicle, and we are giving the SCG. So you are given 5,000, I have given 10,000, someone has given recombinant. Believe me, everything is same. We are just giving because these are more than enough. If you are giving 5,000, you are perfectly all right. If you are giving 10,000, it's okay. But we need a very small amount. Now, why I am giving 10,000, why you are giving 5,000, why she is giving recombinant? Again, the important thing is that we have met three follicles, and we are a very good infertility specialist. We have met the stimulation like a rocking three follicles with very good endometrium. But it's very important that this receptors. No, what happens in normal body? Normally there is FSH and then the LH, a very good follicle. The estrogen releases that leads to LH surge. It's natural. And here what we are doing, we are manipulating the things, but we can't manipulate each and everything. So if we are giving 10,000 SCG, this follicle of 19 millimeter, this is 22, and this is a 20 or 21. So sometimes it happens the receptors get activate here a bit earlier, here a bit late. This may happen. So if we are given 10,000 SCG, the body level is maintained for 2 or 3 days. So if this follicle is released today, this may release tomorrow morning. So the you can say the concentration is high. But the other thing is that we had a precaution also. There may be the conversion of M1 of M2 to all these follicles. That's why when we are giving SCG, the chances of twins are much more. The chances of ovarian hyperstimulation are much more. So the only one point why we are giving 10,000 is that the wider coverage, more concentration. Again, there are lots of questions like if we are given this sorry, if we are given this SCG and the follicle and we have asked for the IUI and the patient come, normally the ovulation happens to 36 to 40 hours, which is written in a textbook. Practically believe it never happens before 40 hours. We have lots of time we have seen. And what is the time of IUI? This is a different chapter, but I can tell you, normally the females would wait for the male to come. The sperms would wait for, sorry, normally the sperms would wait for the eggs to come. So normally the IUI is planned between 36 to 40 hours. So you're given the trigger today to Monday, 2 p.m. So you call your patient on Wednesday early morning and see the scan. And the ideal time of IUI is that when the follicle is collapsing or it's about to release. That's the ideal time. But you have seen that the follicle didn't release. The follicle is stagnant. If you are going, you are scanning on your own, you can see there the signs which say that it's releasing. But for this, you have to do your scan on your own. I can show in the ultrasound picture. So what happens, you have given the trigger, there are lots of questions that मैडम 10,000 दे दिया, अब तो ये release ही नहीं हो रहा. Then what next to be done? If you're given 10,000, then you can repeat the GnRH analog. Again, it's a different how it works. Like GnRH analog is like to say in how much time I have.
Ma'am, we'll end by 10 o'clock. So we have a couple of
Okay,
that have also come in during
but the
this.
questions are also there, no?
Yes, ma'am. We have a few
So I will
questions.
not go in detail of, okay, I will not go in detail of DNS analysis because we have 15 minutes left only. So, okay, thanks, sir. So, secondly, you can give GnRH analog. It's release the LH from central. It go and search the receptors and they release of LH. So, it's much more natural. Not going in detail of the latest things. So, finally, to conclude my talk, I will just say that Ovulation induction, making of ovulation induction, normally for IUI patients is an art. It's not a science. But for understanding, it is very important to understand two or three things. First of all, your first interaction with the patient is very important, very, very important. And at that time, even when you're rough, or if you're comfortable, you can over the prescription, you make a plan. Letrozole, HMG, or because every time the things change. As I told you, ovary is a dynamic organ. So suppose you are making a plan and the 6th day you may change your own plan. अरे यार इसको तो ये देना था. So make an earlier plan, but you should respect your earlier plan. Secondly, always keep in your mind the HPO axis. Thirdly, it is very important that you should know each and every molecule when to be given. Fourthly, it is very important that you should know that what you need on which day. In 7th day, what you expect to see. आपको क्या देखना था और क्या नहीं मिल रहा, या either you are behind or you are adequate or you are ahead. And again, make in your mind a plan of 12 days. कैसे इसको मूव करना है, कब स्कैन के लिए बुलाना है, एंडोमेट्रियम क्या होगा, ट्रिगर कैसे देना है, दिस इज वेरी इंपॉर्टेंट. एंड फाइनली, I always tell it, make a plan for 3 months with your patient. क्योंकि एक साइकिल में 15% से 20% आप देने जा रहे हो. So make a plan for 15 days so that the patient you retain your patient. Because what happens that you have given the false, नहीं IUI करा लो हो जाएगा. And you can't change the whole the what is the data and all, because itna hi hai 15 se 20%. So what happens, as soon as the periods come, the patient leaves even they didn't pick up your phone. So make a plan so that the next time you can explain nicely ki nahi, this was the thing, now we will plan like this. And with this I conclude my talk, and I will be very happy if you had any questions, so that we can interact much more. And I hope it was useful for you all.
Thank you so much, ma'am, for your presentation. We have a few questions that have come in during the session. I will just take them up one by one.
Okay.
Dr. Bhavna has asked, what do you do if we are not getting the dominant follicle in FSH-LH combination?
So actually, Bhavana, it is very important that which day is a scan, what is on which if you're not getting a dominant follicle with FSH-LH combination. Bhavana, if it is your first cycle, as I told you, we have to keep in your mind the FSH threshold. So if you have not you were given gonadotropins and on day 10, you are not able to find any dominant follicle. Then you have to go back to your history. What was your until follicular count? Are you stimulating a 35 years old lady and you have given the underdose? Again, it is very important for the next cycle, go for day 2 LH. Are you stimulating a 80 kg old polycystic patient whose LH is 16? So it will lead to atresia of follicle. The follicle will not grow. So C needs the lifestyle management for the first 2 or 3 cycles. So even after giving combination, you are not able to find what was the day 2 LH. Was it very high? So we have to wait for 2 or 3 cycles and do a lifestyle management and control it. Secondly, if it was the first cycle, patient is not polycystic, patient is not obese, is he elderly and you given lower dose. And thirdly, if everything is fine, see the patient of 26, 28 years old lady with unexplained infertility, then now lesson learned. You just know the FSH threshold is high. So in the next cycle, we can start with a higher dose. You go with the step down protocol. कितना लगाया था, अब कितना लगाऊं? That should be done.
Yes, ma'am. Thank you so much. We have a
Thank you, dear.
next question by Dr. Shala. What is the perfect time for GnRH and when should we give it?
If you're talking about GnRH agonist or antagonist? Again, my question. And are you giving GnRH for agonist for trigger? Are you giving GnRH agonist for downregulation? So, or are you giving GnRH antagonist to hold the follicle because you want to deliver IUI? So, GnRH, eh, this GnRH agonist, antagonist. There is a huge class about GnRH for the practical purpose. GnRH agonist works in two ways. Like if we are giving GnRH agonist continuously, daily dose, it downregulates. If for trigger we are giving GnRH agonist a single dose, then it go and there is a upsurge of LH and it works as a trigger. So what is the question? If you explain me or given my number, so we can explain GnRH for what? And if I am not wrong, if he is talking about the GnRH for trigger, because in this class here GnRH is working for the trigger, and this is GnRH agonist. So the perfect time is when your follicle has been formed and you are given SCG and there is no ovulation, the follicle is stagnant. Then after 36 to 40 hours, you can use GnRH and we call it a double trigger.
Yes, ma'am. They
Shala,
have replied.
you can take my number and you can talk to me personally, or if you will like, I can have a brief class of GnRH agonist and antagonist and its clinical implication.
Yes, ma'am. She's written in the chat right now about it's about GnRH agonists.
Okay, and for the trigger or for the down regulation? For the trigger,
While we wait for their answer, ma'am, can let's trigger.
yeah,
Trigger.
yeah, for trigger. So,
Yes.
Shaila, if we are using GnRH trigger normally in IVF cycles, why we are using GnRH trigger in IVF cycle exclusively? Because in IVF we have multiple follicles and we just want OHS free clinic. And normally we have shifted from fresh transfer to freeze transfer. So in IVF clinic, for trigger, exclusively GnRH agonist, when we feel the follicle is 18 millimeter, 20 millimeter, depending on the whole cohort, and day 11, day 12. But in IUI clinic, the first line of this trigger is SCG because SCG didn't interfere with the luteal phase. But if we have given the SCG and there is no ovulation, then you, as a double trigger, you can use GnRH because GnRH also affects the luteal phase. And if we have given GnRH as a trigger for IUI patient, you have to make your luteal phase much better, more progesterone should be added. So for IUI patients, we use as a second line, and for IVF patient, we use as a first line.
Yes, ma'am. Thank you so much. Uh,
Thank you, dear.
Ma'am, if in interest of time, I'm just combining a few questions.
Fine.
We will have a similar question by here by Dr. Vyoma is what to do if there is no rupture after HCG injection? And another question is that what should we do if the follicle has not ruptured even after 48 hours after HCG 10K trigger?
Yeah, I've explained this. Like, if you have not rupture after 48 hours, you can add GnRH agonist for the trigger. And if the follicle ruptures, do your IY, give a good luteal support. Again, now the question comes even after SCG, even after this GnRH agonist, the follicle didn't rupture. अब क्या करें? So now we label it as a routinized unruptured follicle. Like in these types of patients, you have to hold the cycle for 1 or 2 months, and you can downregulate these patients with oral pills or with estradiol, and restart this stimulation after 1 or 2 months.
Yeah, thank you so much, ma'am. We have
Thank
one
you, dear.
last question here. Uh, what to do if there is an early rupture at 14 mm
Yes.
follicle?
Very good question, Dr. Vyama. Actually, most of the time the patients come to us. I have missed lots of things in these slides. We have not discussed about GnRH antagonist. Most of the patient comes to us that डॉक्टर साहब वो पिछली वाली मैडम के समय ना दे वर प्लानिंग फॉर IUI and the follicle released earlier. मेरे तो हस्बैंड आए नहीं थे because the follicle released earlier. One line, if you remember, I have told you here in the presentation that if every follicle has a different receptors and is there on and off, we can't on and off them. So sometimes it happens like the receptor gets activated earlier. We have seen few patients, the follicle releases at 14 millimeter. We just waiting to give SCG, but the follicle gets out. So in these types of patients, we use antagonist. If you wish, we can take another class of antagonist and agonist. So what we do, because now the patient has become very smart and have warned us, डॉक्टर साहब अंडे रिलीज ना हो 14 millimeter में. So in these types of patients, what we do, we give antagonist and parallel we give this gonadotropins. So the follicle is hold it till we give the trigger. Here the things is in our control. Antagonist is a different molecule which which is a short acting and which hold the follicle till we want. Normally we use in IUI patients like this. These are the rare happening Vyoma that follicles release in 14 millimeter. I think among 500 patients we see like this, but definitely these patients encounter. But sometimes you had a conference or the husband is coming late or you don't want IUI on Sunday. In that case, we give antagonist so that the follicle, we retain the follicle. So at these types of patient by 13, 14 millimeter or by 12 millimeter, start giving antagonist either daily or alternate day by the time the follicle reaches 18 millimeter. And then we hold this and give the trigger.
Thank you so much, ma'am. I think
Thank you,
that
dear.
brings.
I think it was helpful for everyone. And
Yes,
it's
ma'am.
really an honor, dear, for to be here. And sharing my knowledge. And thank you, viewers and listeners. I'm very happy that you interacted with this. And I will be more happy if you share your questions. And I hope I justified the talk.
Yes.
Thanks and bye and good night, all.
Ma'am, I'm sorry, but there's one more question that has just come
Yeah,
in. Can I please ask?
okay.
Yes.
Yeah, yeah.
Uh, what is the role for PRP for endometrium, plasma rich platelets, for endometrium in intrauterine insemination?
Yeah, this Bhavna is very badmaas ladki. So, so role of PRP is very good, Bhavna. But again, you can give the PRP. Suppose it happens like on it's day 10, and you had a very good follicle, like you have 17 millimeters of follicle is reached, and by day 11, 2 or 3, but the endometrium is 6.2. So you are saying क्या करूं अभी trigger नहीं दूंगी फिर endometrium is very thin. In that case you can give the PRP, because we all know that when we are giving the PRP, it takes 48 to 72 hours the endometrium to rise by 1.5 to 3 millimeter. So on day 10, if the follicle is 17 millimeter, but the endometrium is 6.2 millimeter, we can do the PRP, hold your cycle for another 1 day, and give the trigger on next day. And by the time your endometrium is ready. But again, it's very important, Bhavna, that why your endometrium is poor. Now you will say it's a polycystic patient. And they see had a cycle of 35 days. So initially you have to build up this endometrium because normally everything is like you can say as like we हम शादी में अलग तैयार होके जाते हैं हॉस्पिटल में अलग और मार्केट में अलग. So normally we keep PRP for these poor IVF chaps. But even though we can use in IUI, even after all the efforts, the endometrium is not good. And we're taking in mind that when we are giving the trigger, our this endometrium is 7 millimeter. Then only, but definitely we can use PRP. There is no harm in using that.
Thank you. That truly brings us to the end of the session and the Q&A part of it.
Thank you,
Thank
dear.
you so much,
Thank you,
ma'am.
and good night to all of you. Thanks a lot.